Hello, everybody. I think I'm live now. This is Dr. Rajat Jain. I'm in consultant intervention cardiology at Care Partners Heart Center, Healing Touch Hospital, Ambala City. So, I'll be doing this live chat and live streaming regarding the importance of the heart rate in health and in diseases. So, heart is one of the simplest cardiovascular parameters. It usually ranges between 60 to 80 beats per minute, as we all know, and we have already read about it in our schools, and it occasionally exceeds more than 100, or it gets below 50 occasionally, depending on the patient activity and the level of conditioning the patient has. A conditioned and trained athlete can have heartbeat as low as 35 to 40 beats per minute. So tachycardia is usually defined as beats more than 100 per minute, and it can be treated as a prognostic factor in myocardial ischemia, in hypertension, in low cardiac output, in peripheral hypoperfusion, in cardiomyopathy, in cardiac arrest, or in death. If we carefully assess the tachycardia, we can assess the prognosis and the cause of the tachycardia. And ECG is the most common tool to diagnose the tachycardia. And healthcare professionals, they may use other methods like Holter monitoring or event monitoring, and stress test may also be beneficial. Now, coming to its management, an aggressive approach towards the diagnosis is first necessary to diagnose the cause and the underlying culprit that is causing the tachycardia. It might only be a response to heightened activity or adrenergic stimulus, but it can be due to the underlying heart failure, or it can be due to the underlying ventricular tachycardia or some other life-threatening events. So external cardioversion can be performed safely in even in an outpatient setting if the patient is having these life-threatening underlying events. And of course, we do have a lot of intravenous antiarrhythmic drugs. We have a whole lot of classification. Won't go into that because it would be beyond this. Fibrillatory waves in the atria. Hypertension and hypertensive heart disease is one of the most common cause of atrial fibrillation, but among the Indians, the most common cause is rheumatic heart disease that affects the mitral valve and causes the mitral stenosis or the regurgitation, leading to atrial dysfunction and causing atrial fibrillation. It may be symptomatic or asymptomatic, and the most common symptoms the patient present with either is palpitation, dyspnea on exertion. It may be some chest discomfort. It may be lightheadedness. Patient may present with the syncope if there is very high heart rate. Patient may present even with the paralysis or what we cerebrovascular accident due to the ampulla which is formed in the fibrillating atria, and the patient is to be treated according to the guidelines. Patient has to be anticoagulated if indicated, and the patient has to be given the rate control measures. And coming to the most easiest way to diagnose the atrial fibrillation is looking at the pulse. If the patient is having irregular patient is having the underlying risk factors, then of course the first diagnosis that should come to the mind is atrial fibrillation. And of course, the history is necessary if the patient has any other history of any other tachycardia, or is being under treatment, or is with the irregular treatment, and the patient is having irregular symptoms or having paroxysmal symptoms, then that of course 24 or longer Holter monitoring may be helpful. Of course, the underlying cause is to be diagnosed. The first thing that should be done is the 2D echocardiography, which shows the left ventricular function, valvular function. That is the most common causes these days in the causing the atrial fibrillation. Now, coming to the management of the atrial fibrillation, now the rate control is our first target, and of course, the rhythm control is also targeted if the patient is having it for less than 48 hours, or the patient has been adequately anticoagulated for last 3 to 4 weeks. And of course, the patient is to be kept on anticoagulation for more 3 to 4 weeks. Pharmacological cardioversion can be done by intravenous ibutylide, which is available now in India, or with amiodarone or procainamide, or it can be done electric cardioversion if the patient is hemodynamically unstable. Now, the other life-threatening tachycardia is ventricular tachycardia. It is a wide complex tachycardia as seen in the ECG, and patient may present either with chest pain, dyspnea, lightheadedness, syncope, or sudden cardiac arrest, or aborted cardiac arrest. The rate may vary from 100 to 250 beats per minute. It may be irregular. The beats may be the ECG may show undulating waveline, suggesting Torsades depointis, which is immediately life-threatening and has to be dealt with immediate electrocardioversion and excuse me, correcting the underlying fault that is causing the ventricular tachycardia, that may be electrolyte imbalance. And if it ventricular tachycardia may also be non-sustained if it lasts less than 30 seconds, and this is said to be sustained if it lasts more than 30 seconds. It usually originates distal to the his bundle, and it in the ventricular muscle or in the specialized conduction tissue, or combination of both. Patient who survive the sustained tachycardia, they have to be thoroughly evaluated with the 2D echocardiography, all the relevant blood investigations, and depending on the history, the presentation, patient is to be dealt either with the ICD implantation, or maybe given, if the patient is hemodynamically stable, then patient can be just sorry. The patient is hemodynamically stable, then the patient can be managed medically. If the patient with symptom is suspected detect and the patient is having paroxysmal symptoms, the patient can of course be kept on Holter monitoring for a 24 hours or longer period. So that is how we deal with the ventricular tachycardia. And the other tachycardia we come across is supraventricular tachycardia, where the origin of the foci is above the AV node, and it is usually a narrow complex tachycardia, and the most commonly we come across is AVNRT or the AVRT, that is paroxysmal supraventricular tachycardia, and the treatment is with AV node blocking agents. It is usually not life-threatening, but patient is to be thoroughly evaluated with blood investigation, electrolytes, and thyroid function, and of course, and 2D echocardiography does not harm. A patient can present with palpitation, low lightheadedness, chest discomfort, or only with anxiety. ECG should be performed and the diagnosis is made. If the patient is hemodynamically stable, then the patient is managed medically with intravenous adenosine or intravenous diltiazem, and maybe intravenous beta blockers. And the patient is somehow hemodynamically unstable, electrical cardioversion is indicated. If the patient is having underlying coronary artery disease or history of myocardial infarction, patient should be suspected for ventricular tachycardia, and patient should be managed accordingly. And if you do not have the intravenous approach or the drugs are not available in outpatient setting, then the Valsalva maneuver is the simplest method to which can be tried to terminate tachycardia. I've personally experienced that many tachycardia do stop after the Valsalva maneuver, and the long-term management is either by electro EP studies and ablation, or patient can be kept, if the patient does not prefer EP studies, then the patient can be kept on medical management, but of course the efficacy is lower as compared to the EP studies and ablation. Now coming to the bradycardias, bradycardia is are the cardiac rhythm when the heart rate is less than 60. Of course, everybody having the heart rate less than 60 cannot be treated as bradycardia because, of course, the trained athletes or the patients with low adrenergic drive can have a physiological rate of around 45 to 50 per minute, and if they don't have any symptoms, then they don't have to be treated or evaluated. The most common cause of bradycardia is usually sinus bradycardia. It might be due to some underlying health issues or maybe age related, that is left disease, and the treatment is it usually presents in the elderly patients who do have history of concomitant heart disease. Of course, the underlying drug history is to be taken if the patient is on beta blocker or some other sinus node depressing agents like calcium channel blockers or ivabradine. Then the drug has to be taken off before treating the patient. History and physical examination and other relevant blood investigation are needed. If the patient might be in the chronic kidney disease, patient might present with bradycardia or AV block with hyperkalemia, then only the underlying treatment of hyperkalemia can treat the bradycardia. The respiratory rate, pulse rate, blood pressure, saturation, all are to be noted and treated accordingly. ECG helps to make the definitive diagnosis. Of course, again, the patient is having paroxysmal symptoms and the patient Holter monitoring 24 hours or longer is needed. A patient having underlying infectious etiology may also present with bradycardia, like sometimes seen in typhoid. So coming to the treatment of bradycardia, if the patient is symptomatic and patient is having sinus node disease and the patient is not if, thought to be recovered, then the patient is treated with the permanent pacemaker, either with dual chamber or single chamber as indicated. Urgent treatment is done by giving intravenous atropine and putting a temporary pacemaker in situ. If the patient has any other underlying disease like hypothermia, then the correcting of hypothermia might lead to the improvement. Patient may present with syncope, pre-syncope, lightheadedness, palpitation, easy fatigue, and the patient may also present with dyspnea on exertion if the patient is having underlying bradycardia. So most commonly, that is patient is having sinus node dysfunction or AV node dysfunction, and the patient is treated accordingly. So I think I've discussed the basic of the heart rate, and if there are any questions, so you can type and ask. Otherwise, I think we'll come up with some other topic next time and we'll discuss it. Any questions? You can ask on the chat, live chat on the right side. Guess not. Thank you. So this is Dr. Rajajan signing off. Bye.